Twice.
So, Manjunath sir, namaste sir.
Namaste, sir. Good evening, sir.
Namaste. Good evening, sir. Warm welcome to you, all of you, esteemed delegates. We first welcome our own senior faculty, Dr. Hitesh Rajiv Sakai, sir. Can all of you mute, please? And today will be a 304th session of our PG clinics. We have
Namaste, sir.
Namaste, sir. Good evening, sir.
Good evening.
Namaste, sir. Good evening, sir. Warm welcome to you, all of you.
I'm sorry. So, friends, this will be our 304th session. We have very eminent faculty joining us today. I warmly welcome our own faculty, Dr. Sakai sir, Hitesh Andarya sir, and we Nishi sir. Nishi sir will be the host for this evening program. We have Professor Manjunath Kotenavar sir from Vijaypura and Rohit sir from Chandrauli. So, warm welcome to both of them. And we have two candidates. Dr. Smith is kindly contributed by Dr. Hitesh Andarya sir from Narendra Modi Medical College, Ahmedabad. He'll be presenting a case of peripheral artery vascular disease. And we have another case kindly contributed by Dr. A. Ramakrishnan and Dr. Prabhakaran sir. Sir will be presenting a case of multinodular goiter. So we first will be taking Dr. Smith Shah. Second, we'll be taking Dr. Lalit Kumar. Smith, please switch on your video. Yes, please share your PowerPoint. Please introduce your unit chief, HOD sir, and then start your presentation. Nishi sir, please take over, sir.
Sure, sir.
Hello. Good evening, everyone. Is my PowerPoint visible?
Make slide slow. Slideshow.
Smith,
Yes, sir.
slideshow, please.
Make it a play mode, ma. On the right lower thing, there is one screen-like thing, if you see. Next to that minus mark, yes, press that.
Yes.
Go to the first slide. Faculty, please
Hello.
take over. Thank you.
Yes, sir.
Good luck, Dr. Smith.
Thank you, sir. Hello. Good evening, everyone. My name is Smith Shah. My PG teacher is Dr. Hitesh Andarya, sir. I am from Narendra Modi Medical College, Ahmedabad. I am presenting.
Can you hold for a minute, Smith?
Yes, sir.
Faculty and students, I'm muting all of them. There has been some disturbances. Please unmute those who wish to speak, sir. Sorry for this. So, please, all of you who are faculty alone, please unmute themselves. Others, please keep in mute mode, please.
Smith, you also unmute.
Yes, sir. Sorry for this inconvenience, sir. There have been some constant disturbance from someone. Faculty, please feel free to unmute yourself and ask. You can unmute yourself at any time at your convenience. Thank you very much,
Smith,
sir.
unmute. Smith, unmute.
Yes, sir.
Yes.
He is already. Start, Smith. Sorry for the inconvenience, all of you.
Hello. Good evening, everyone. My name is Dr. Smith Shah. I am from Narendra Modi Medical College, Ahmedabad. My PG teacher is Hitesh Andarya, sir. I am presenting case on arterial occlusive disease. History. A 55-year-old gentleman, mentioned by occupation, residing in Ahmedabad, came with the chief complaint of pain in the left buttock for 18 months, pain in the bilateral calf and right foot for 6 months, blackening of the right toe for 2 months. ODP. Patient was apparently normal before 18 months. Patient was apparently healthy before 18 months. Then he developed cramp-like intermittent pain over left buttock, which occurs only while doing work. But he can continue work with pain. Sometimes, for pain relief, he take over-the-counter medications to continue work. Before 6 months, he developed similar intensity of cramp-like intermittent pain over the bilateral calf region, which was initially in right side and later on developed on the left side and on the right foot, which compelled him to stop working. Initially, he was able to work Initially, he was able to walk about approximately 500 to 600 meters before taking rest. It gradually progressed over time, and currently he can walk only 40 to 50 meters. And then he had to take rest and can't continue walking any further. He has also erectile dysfunction for 6 months. Before 5 months, he took consultation and basic investigations were done, and he was managed conservatively on medical treatment. Since 2 months, he had rest pain in the right foot, and to get relief from the pain, he kept the feet near to the body or kept the feet hanging from side of the bed. Before 2 months, due to trauma, he noticed small ulcer over the dorsum of the right great toe. Ulceration gradually progresses over time and leads to blackening of the great toe. There is no history of transient blackouts, syncopal attacks, or blurred vision. No history of any chest pain or breathlessness. No his-
Hello, Smith.
I think he has disconnected himself.
Some network issue.
Yes, as usual. They don't.
Manjuna sir, good evening.
Good evening, sir. How are you, sir?
I am good, sir.
These are being in the same place. We are meeting on Zoom platform.
Yeah.
Sir.
Thanks to COVID and Kanakbel, sir, we have been meeting regularly.
Yeah, sir.
Barely we knew many of our colleagues
Yes, sir.
before that.
Yes, sir.
Can someone contact him?
I'll call him.
He's come back.
Am I audible?
Yes,
Yeah.
you are.
Sorry for the disturbance. No history of transient
slide.
blackout, syncopal
slide.
attacks, blurred vision. Sorry, sir.
Carry on, full
No,
slide. Carry on.
no history of chest pain or breathlessness, no history of postprandial abdominal pain, nausea or vomiting, no history of ulceration or swelling in other part of the body, no history of any new onset back pain or any symptoms which relied on forward bending, no history of similar complaint in the past history and comorbidities, no history of any other comorbidities like hypertension, diabetes, ischemic heart disease, no history of any similar complaint in the past, no history of any past operative management. Personal history, patients taking mixed diet with unaltered bowel and bladder habits and decreased sleep. He is a chronic smoker, smoking one packet of BD daily for 45 years. Pack year index is 45. He is chronic alcoholic for 20 years. Family history, no similar history in the family. So I should continue or
Yeah,
No,
please
please,
just
yes.
summary of that.
summary. 55-year-old gentleman having complaint of clamp-like intermittent pain over left buttocks since 18 months, bilateral calf and right foot pain since 6 months, with rest pain since 2 months, with blackening of the right great toe since 2 months, with chronic smoking addiction and no comorbidities, would be most likely due to the arterial occlusive disease, most probably at the level of aortoiliac.
Dr.
Okay,
Smith,
so please.
Dr. Smith, can you hear me?
Yes, sir.
You use one short form, that ODP. What is that ODP?
Origin, duration, and progress.
See, don't use such non-universal short forms, isn't it?
Okay, sir.
What
Some throat
do you
like
mean by ODP?
joke.
What do you say ODP is?
Origin, duration, and progress.
Origin?
Some throat-
What is this?
Repeat
Origin?
it.
Sorry, sir.
What do you say ODP is?
Repeat it, Dr.
Origin,
Smith.
origin, duration, and progress.
Where did you get this term from? Is it standard?
Origin, duration, and progression is telling.
What do you mean by that? Origin,
SOPI.
duration, and progress? What do you mean by that?
Uh,
Origin, distribution, and progress?
how the what would the patients means how the disease started. What was the how means when it was started?
Oh,
What?
okay, fine. Where did you get this term from? Is it
Is
commonly
there any
used in your
reference?
hospital?
Is there any reference to any clinical manual books you have referred it? Dr. Smith,
It's
please
coined by
don't try to use that.
Dr. Smith.
Okay.
Okay, sir.
Okay,
Because
let's go to
many
your first slide.
Dr. Smith.
history of
Dr.
presenting in
Smith.
Yeah, let's go to your first slide.
Dr. Smith.
Yes,
Yeah,
sir.
where your name. No, before that, where your name is written. Look, Smith,
Yes, sir.
these kind of small things, they just reflect on how careful you are as a surgeon. Smith Shah with a small s just reflects on how careful you as a surgeon you can be. How minutely. Look, a surgeon has to be very careful, thinking and look at minute details. Right? Right.
Yes, sir.
Don't
Dr.
worry.
Smith.
Yeah, next slide. So bilateral calf pain, right foot, left buttock, right toe. He's got it all over his lower limb.
Yes, sir.
Right? Okay, next slide.
Dr.
This is
Smith.
Ramayan. This is full Ramayan on the slide.
Dr.
Make it
Smith.
small. So
Your slide
right.
should contain 4 or 5 lines. You
Okay,
copied
sir.
all
Right.
text.
I mean, I can't. It's like reading a whole chapter for me, a whole
Yes.
page for me. Right? I'm not. I can't. You have to just glean out the important. 18 months cramps, cramp-like intermittent pain. What do you mean by that? Look, you have to, in history, you have to give us the full Socrates, site, onset, character, right? So you give that.
Dr.
While
Smith,
doing
how
work,
you will
what work was he
present?
doing? No, what work is he doing? Suppose he's working by hand. He's running a loom. Does he get pain? What work?
He is doing uh, he is a laborer by occupation, means he is building homes, means doing heavy work.
You show
See
your
that.
slide of occupation. Show your slide of occupation.
Occupation by, right.
Math.
Mason by occupation. So masons generally they sit, they don't go up and down, do they? Not much of walking for him. So it's on standing. Is it on walking? Just go back. Just next slide. Next slide. Like occurs while doing work. I mean, you have to tell me what kind of work. But he can continue work with pain.
You better mention walking, Dr. Smith. Why you want to mention
Yes,
that
sir.
work, broader sense, isn't it? It is in the lower limb. Let me mention better walking,
Climbing
isn't it?
stairs, walking. Okay. Some time for pain relief. He take over the. Okay. So you just write relieving factors over the counter medication.
Okay.
Before 6 months, he develops similar intensity cramp like. So this is 18 months. Say six, not before 6 months, at 6 months
Okay.
or after 6 months. Intermittent and bilateral, both initially in right side and later on left side. After how long? Which started first? Right started. After how
Right side
long did he
started
develop
first.
on the left? After how long did he
After
develop the
5 to
left?
7 days.
Okay. So I mean, right foot compel him to stop working. Initially, he was able to walk. Now it's working. It's walking. 500 to half a kilometer is walking. Claudication before taking rest. Half a kilometer is great here. I mean, there's no. I won't say there's intermittent. I walk for half a kilometer fast. I get pain here. So that doesn't qualify it as intermittent claudication. It's a distance which normally a person can cover, but this fellow can't because of pain. Right? 500. If you say walks a kilometer, fine, yeah. And then had to take rest and can't continue walking further. Erectile dysfunction. What kind of erectile? Does he have? You have to. He has. Does he have early morning tummy sense?
No, from last 6 to 7 months, he has no morning.
So you have to mention that. You have to mention that. You have to. We want erectile dysfunction can be with the partner. Is it all the time? If he has early morning emesis, there's no erectile dysfunction. Okay, it can be
He doesn't have
psychological.
a morning. Okay,
Exactly,
sir.
it can be psychological. So you have to distinguish between
Yeah.
that.
What is his
Next
age,
slide.
Dr. Smith? What is his age? Age of the patient?
55.
55 years. Is he a diabetic?
Non-diabetic.
Non-diabetic or not a non-diabetic?
No, he is not diabetic.
He's not a non-diabetic. Okay, okay. Do you want to correlate this erectile dysfunction with the dysfunction with this disease proper? Do you want to correlate
Yes.
this?
Yes, I want to call it. It points towards the Goitre syndrome.
Can you tell what is Larry syndrome?
There is the buttock pain. Then there is the thigh or calf claudication with erectile dysfunction or impotence.
Where will be
Together,
the
it
occlusion? Where will be the
sorry,
occlusion? Where will be the occlusion? Pardon?
aortoiliac.
Aortoiliac or bilateral you can mention, isn't it? Bilateral common iliac.
Or at the
If
level
that
of
is the case, yeah. If that is the case, patient would have pain in both bilateral buttock region. In this case, patient had pain in only one buttock, isn't it? Only left buttock.
Initially, it can be at the level of the iliac region. So only left side is involved.
No.
Or
In
there
18,
can be development
18
of
months,
the
18 months is quite a long history, isn't it? 18 months is
there will be
quite a long
development
history, 1.5
of
years.
collaterals. Development of collaterals on the
Dr.
right
Smith,
side. So yes, sir.
what is
That may be
claudication
age
by
related.
definition?
Sorry, sir.
What is claudication by definition?
Intermittent pain, intermittent pain like intermittent cramp like pain, which was not initial at the first step. Patient has to take exercise or walk, and pain is
You are
resolved after taking
describing
rest.
the terminology, not you are defining the. You are not giving
Claudication.
definition. What is
Claudication means limp. Simply means limp. To limp.
No, that's the literal meaning.
So what
What is the definite? That's the literal meaning. That is etymology of the word, right?
Okay.
and
Origin
what are
of the
the
word.
grades of claudication?
Definition of claudication.
Cramp like pain.
Yeah.
Pain
Cramp
while
like
walking.
Pain
While walking, while
Dr.
while
Smith.
exerting.
walking.
Dr.
So
Smith,
don't limit yourself to walking.
claudication is a cramp-like pain felt in a specific muscle group due to deprivation of blood supply. This is definition of claudication.
Okay.
How
Upon
they are
exertion.
how it is classified?
It is divided into 3 types by Boyce
What is
classification.
level 1? Grade
In
1.
level 1, patient starts to walk. Patient feels the pain, but patient can continue to walk, and pain disappears.
Again, you are describing it. Pain passes on continued walking.
Okay.
That is grade 1. Grade 2.
Grade 2, there is pain, but patient can continue to walk with pain with limping.
With effort. That is grade 2. And grade 3.
Due to pain, he can't walk further. He has to take rest.
And what is grade 3?
Patient walks, then he suffers
Pain
but he
compel him
can't
to take the rest.
take
That
rest.
is grade 3. And what is rest pain?
Rest pain is the pain due to cry of dying nerves.
That
Continuous
is another
pain,
terminology.
continuous pain day and night without any work or exercise or walking is known as rest pain.
Where continuous pain in
the distal extremities.
distal extremities.
Distal most extremities.
Is not correct. Continuous pain on feet or toes in the region even after taking the rest. What is cause for this rest pain?
Decreased blood
Dr.
supply.
Smith?
Yes, sir.
Hello, Dr. Smith.
Hello. Hi, sir.
What is
Yes,
cause
sir.
for this rest pain? What is aggravating factor? What is relieving factor?
Due to decreased blood supply in the digital arteries of the foot or the toes.
That is not due to decreased blood supply. This is due to the ischemia of the somatic nerves.
Okay, Dr. Smith,
These are the opening
I'll just
question
ask
in
you
your
one question.
Viva.
You
Yes,
said that grade 1 is that the patient has pain and he keeps walking and the pain disappears. Why does that
Yes,
happen?
sir. Due to the pain occurs due to the substance peak. What are the substance peak? Due to what are the substance peak, pain disappears.
Is that the reason, the correct reason? What
Why
happens
they are
with
walked off?
the
Why
what
these are walked
collaterals?
off? Yeah.
What are collaterals?
Due to any obstruction or stenosis, the blood cannot come to the distal part. So to compel that, body develops collaterals
So
between
what
the proximal part
happens?
and the distal
Right,
parts.
right. It's okay. That's fine. That's fine. So what happens that when when he's walking, the main arterial supply cannot give it enough, is insufficient for the flow. So it gets pain. Then the collaterals open and the blood flow increases and the pain disappears. Okay, let's go to your next slide, please. So anyone, sorry. 5 months ago, he took consultation. Look, all this, this line has got no, it just means nothing here in history of it. Just say that that is into medical history or a treatment history. Since 2 months, he had breast pain in right foot to get relief. Before 2 months, since 2 months, before 2 months,
Smith,
small ulcer, dorsal.
when do you use since and when do you use for? Smith,
Yes, sir.
when do you use the word since and when do you use the word for?
Since means continuous. Continuous means he has a continuous history from last 2
No,
months
No,
or
no.
2 months.
Smith,
no,
hang
no.
on.
Listen to the
Smith,
question. For describing any duration of any symptom, when should you use the word since and when should
for
you
two
use the
months
word
and
for?
since 2 months is which one is right and which one is wrong? For 2 months, since two
And
months.
Since 2
since
months.
since Sunday morning and for last 1 week, which is correct? If patient says that I am having pain since, I mean, even I cannot use the other word.
Okay,
Pain,
Smith. We'll just
right?
correct it. It is if you know if there's a definite timeline from
Yes.
since September and for 4 months. Okay, next slide. No, 2 months ago he had due to trauma. What kind of trauma?
While he was walking, due to any stone injury or due to he doesn't specify any trauma, just due to any injury, he noticed a
Okay.
ulcer.
So usually, this do you think it's because of trauma?
Might not be. He just noticed due to trauma. It might be
So it might have been
before
brought to
that.
his notice because of trauma. So
He
there's a
just
smaller.
noticed of due to trauma.
Now this ulceration gradually progress over time, leading to blackening of great toe. Okay. Any smell? Any
No.
pain in the ulcer?
Uh,
Any discharge from the ulcer? Look, now
yeah, when
that you
the
have mentioned
patient
the
came,
ulcer,
huh,
you have to take the history of the ulcer now completely. You just can't say it progressed. Was it painful?
okay.
What was it? Was the discharge? What kind of discharge was it? Like, was it pus? Was it blood? Was it just serous fluid? Right?
Just serious fluid. He said of just serious fluid. When the patient came
No,
to us,
okay, that's fine. You might have. I'm pointing out that these are the deficiencies in the history.
okay.
Okay, next slide. So he doesn't have a global feature of arteriosclerosis.
No, just involving the lower limb. No any global features.
Right. So just write no evidence of global involvement of atherosclerosis
Okay.
instead of writing a whole Dobie list.
Okay.
Right. Next slide.
Dr. Smith,
History of
why are
similar companies. What?
let me interrupt here, sir, please.
Sir, please.
Go back to previous slide, Dr. Smith. Why are you specifically telling this no history of any new onset back pain or any symptom relieved of forward bending?
Just to
Suggestion?
to just differentiate from the neurological claudication. If as the patient has just unilateral gluteal pain or buttock pain.
No,
Which
okay.
kind
How
of,
do you? Sorry, sir.
uh,
Sir, please.
what are you expecting here? What do you want to rule out exactly by asking this question? Is it a routine in case of arterial occlusive disease for you? Is it a routine question?
Sorry, sir, I can't got the question.
No. You
Can
have
you just
specifically ruled out this negative history, isn't it? Specifically, you are highlighting
uh,
this negative history. Is it a routine for you? Is it a routine question to be asked in a case of arterial occlusion disease of lower limb?
no, sir,
Already
because
you
just
mentioned
patient
there is
has
no history
only
of
just
post-traumatic
unilateral,
pain.
just patient has unilateral buttock pain. So just I asked to rule out any back pain or any any
Okay,
neurological
Smith, I agree
condition.
with you. Smith, I agree with you.
What?
But you tell me, how will you, by history, distinguish between neurogenic pain and arterial pain?
In neurological pain, the patient will have pain on the start of the movement or start of the exercise or the walking.
Exactly. Exactly. This is what sir is trying to point out to you.
Yeah.
That this low back pain and all, everyone has some low back pain here. Even I get low back pain. So that doesn't mean I'm having neurogenic claudication.
Yeah, one more thing, at looking at your that negative symptom, what we feel is you want to rule out pancreatitis because you're non-alcoholic also. Back pain getting relieved on forward bending, isn't it? That symptom can be there in a patient suffering from pancreatitis, chronic pancreatitis. And pancreatitis has nothing to do with arterial occlusive disease, isn't it?
Yes, sir.
Any history is not
So
there. Why you want to commit that? Any history is not there, isn't it? Why you want to commit it? Totally unrelated, isn't it?
so
So
you
better
have to
you
say
should
where,
not tell this.
which part of the back is low back.
Yes.
Yeah, you meant low back. So you
Yes,
have to
yeah, I
write
meant
that
low back.
out here.
Okay.
So better don't tell it. Any of it is not there,
Don't tell
better
it
don't
at
tell
all. It means nothing. Means nothing. You don't rule out neurogenic claudication by this.
Okay.
Okay,
Okay,
next
next
slide.
slide. Sir, please.
No history of
Unaltered.
similar
What do you mean by
disease.
unaltered bowel? Unaltered bowel and
Means he's having regular bowel motions, one time a day,
just
and
write
normal.
normal
No.
Okay,
bowel
sir.
and blood habits.
Okay, sir.
Chronic alcoholic, chronic consumption of alcohol. Who's an alcoholic? Who's an alcoholic? Someone who can't live without alcohol, who gets withdrawal symptoms when they don't get alcohol.
Alcohol.
Does he get that?
Psychological and physical.
Has he got Wernicke's?
No, sir.
Then, okay.
Okay, Dr. Smith, you have mentioned no history of similar complaints in the past. Can you tell in which disease you can expect such as similar complaints in the past? Name some
Means
diseases.
in arterial only.
Which type of arterial disease, acute or chronic?
In case of any acute condition which he might have before, like any
Like-
embolus,
Yeah,
any
yeah.
emboli or any thrombus formation before, or any cardiac condition he might have before that might he have.
Yeah, most of the time they are acute in nature, isn't it? Like acute
Yes,
thrombosis or acute thromboembolization, emboli. Isn't it? This is a case of chronic vascular disease, isn't it? The
Yes,
chronic artery inclusion patient can have previous history of acute arterial occlusive disease.
okay.
And in this case, usually they will be having associated comorbid disease, like disease of the
Yes.
heart, isn't it?
Heart.
Can you name some
Heart
conditions
or
of the heart, some conditions of the heart, disease of the heart, wherein patient is prone to develop thromboemboli?
atrial fibrillation, rheumatic heart disease.
Don't say atrial fibrillation. That is totally electrical disease, isn't it? Mention rheumatic heart disease or valvular
Rheumatic
heart
heart
disease.
disease. Vanilla.
Valvular heart disease, bacterial endocarditis, isn't it? A old case of MI, wherein some of the segment, fragment of the necrotic or ischemic wall can act as a thrombus that can get dislodged to form an embolus, isn't it? Very good, very good. Please proceed.
Okay.
Continue with the general examination.
Look, your summary should be those points which favor your diagnosis and those points which rule out the other differentials, right? So having complaint of cramp-like intermittent pain, just say pain left buttock
Okay.
for
Hmm.
18 months, bilateral calf and right foot pain since 6 months, with rest pain in both, rest pain in which leg?
Only on
Right.
right leg. Yes.
Yeah, so right, rest pain of right leg since for 2 months, with blackening of right great toe for 2 months, with history of chronic smoking and alcohol, with no comorbidities, probably due to arterial occlusive disease at the level of arterioiliac junction. Okay, which is the most common site for arterial occlusive disease?
Superior femoral artery.
Why? Where is superior? Which
Sorry,
is the
sir.
most common site?
For atherosclerosis, sir.
Hmm?
Sorry, sir. Once again, the question.
The question is, which is the most common site for atherosclerosis or arterial due to arterial occlusive disease due
Infrarenal
to
aorta.
atherosclerosis? Huh?
Infrarenal aorta. Infrarenal aorta.
Inside aorta?
Infrarenal.
I can't hear you.
It's
He
infrarenal
said
aorta.
infrarenal aorta.
At the bifurcation. This is the most common site. Why? Which are the common sites? Okay. Why at this site? Why is at this bifurcation?
Because at
Arterioiliac
the
bifurcation.
bifurcation, the blood which comes, it causes turbulence, and due to turbulence, it causes the endothelial intima
Okay, that's fine.
destruction.
So turbulence is the cause. Now, which that is one. Where else is which is the next common? What is the next common reason? One is turbulence at the bifurcation. Which is the next common site?
Uh, at the carotid artery.
Aortic?
Carotid artery.
No.
Is that I'm
The
audible?
artery. You have the femoral. You have the adductor canal. Places where
Superficial
the
femoral.
artery passing through a small opening, so that the thing doesn't get enough space to expand. Okay. Okay, sir, please. Anyone?
So what is your in mind conclusion, summary of this? What do you think he's suffering from?
He is suffering from central arterial occlusive disease, most probably at the level of aortoiliac junction.
Probably pathology. Probable pathology.
Probably due to atherosclerosis.
Atherosclerosis. Why can't it be Bursar's disease or TAO? History wise?
In Bursar's disease or TAO, it mostly involves the small or medium vessels disease. Patient is young age, that is below 40 to 45 years of age.
Smith,
Because it's more
first,
common in younger age group.
Smith, don't shake your heads like that.
Okay, sir.
Don't be a Russian doll. Okay. You've not mentioned Lehigh syndrome in your summary.
Yes.
Yes, sir. I just forget.
No, so you should not forget. These are important things. Okay.
Yes,
Yeah.
sir.
Should we go to the examination? So,
Okay, please proceed with the examination.
General examination. I examine the patient in proper light with adequate exposure with due informed consent from the patient. Patient is conscious, cooperative, and oriented to time, place, and person. He is adequately built and adequately nourished. He is comfortable in sitting position with both the legs close to the body. Vitals. Pulse is 86 beats per minute in right radial artery with normal rate, rhythm, and volume. Blood pressure is 132 by 80 mmHg in right brachial artery. No evidence of failure, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Inspection. Dry and shriveled black light gray toe involving distal and proximal part of the pharynx with line of demarcation passing obliquely from medially
Dr.
to
Smith.
ventrally. Yes,
Dr.
hang on.
Smith. Go for
Smith.
inspection. Go for general examination. He is comfortable in sitting position with both the legs close to the body. What does it mean?
Patient is having the rest pain, so he can't. So he's having continuous pain while supine.
Patient
So
is
he
having
can't-
rest pain. What is position of the patient or position of the leg when patient is having rest pain?
He kept
How it is
the leg,
classically described in books, standard textbook.
patient kept the leg side of the table, examination table, or kept the legs hanging by the table.
But you have mentioned that a patient is comfortable.
Means he kept the leg close to the body. While he extend the legs in the supine position or standing position, he's having pain. So he kept the leg close to the body. Uh,
What pain is more in the rest or in the night? Sorry, why pain is more in the night? Rest pain.
because in the night, there on the blood heart comes slowly. There is relatively bradycardia. Blood pressure is low, and so there is no any gravity effect, no help of the gravity. So the pain is more in the night.
There are other reasons, Smith. It's cooler at night,
Yes.
Uh,
it is quieter at night. He's got no distractions, right? So he's there. Okay, let's go to your regional examination. I have a very strong reservation about your regional examination. You can't just go straight away to the right great toe. Do you get me?
yes,
God
sir.
has given
All the
two limbs, two hands, two eyes, 2 ears. Compare the two first. We want to
okay.
know whether the two limbs are of normal size, normal structure, normal position, right? What are the skin color? Compare the skin, compare the bulk.
Hmm. Okay. I just written, but it is just below it.
Yeah, go on.
On inspection, there is dry and swivel, like right great toe involving distal and proximal part of the phalanx with line of demarcation passing obliquely from medially to laterally over the right great toe, seen over both dorsal and plantar aspect. Skin over bilateral lower limb is thin and shiny with loss of hair over the dorsum of the foot and brittle nails over bilateral lower foot. Muscle wasting is seen in bilateral calf, more on the right side than the left side, and bilateral thigh region. No ulcer or dilated vein seen on the left lower limb. These are the pictures of the patient. Here, the line of demarcation is seen clearly on the dorsal side, and this is on the plantar side.
What is his BMI?
Uh, sorry, sir, I have
Have
not
you taken?
taken BM.
Is it
No, sir.
important here?
Mm,
Okay, go on. Go
yes,
on.
sir.
We'll talk about it.
On continual inspection, Burgess vascular angle is 40 degree with failure in both limb. Capillary filling time is 15 seconds in both limb. Venous filling time, cutting of veins seen at 30 degree and venous filling time is 12 seconds. On palpation of right lower lip, temperature is cold on palpation up to right mid thigh. No tenderness seen. Dry, hard, and swivel right great toe, extending till lateral part of the proximal great toe with loss of tissue on lateral part and bony fillings palpable on lateral part of the great toe. Loss of sensation in the blackened part with hyperesthesia above the proximal part of the ganglion at the level of metatarsophalangeal joint. Minimal movement at the right great toe metatarsophalangeal joint, while the movement on the left metatarsophalangeal joint, ankle, knee, and hip joint were in normal range. Tone and power of the lower limbs were normal. No tenderness or edema over left limb. Capillary refilling time is immediate in both limbs. Venous capillary time is Harvey's sign, immediate in both limbs. Girth of the limb. In right limb, at the mid calf level, it is 21.5 centimeter. In left limb, it is 22 centimeter. While in the mid thigh region, on right limb and on left limb, it is both 31 centimeter. Cross leg test is which test oscillatory movements are absent. No lymph nodes were palpable. On palpation of peripheral pulse, there are no pulses, no pulse palpable on the right side and left side of dorsal pedis, posterior tibial artery, anterior tibial artery, popliteal artery, and femoral artery. While the remaining pulse, like the radial artery, ulnar artery, brachial artery, axillary artery, subclavian artery, cavity artery, and fissural artery was palpable on both the sides. Auscultation, no bruit heard. On systemic examination, on CVS, S1 S2 were heard and no murmur were present. On respiratory, bilateral LNP were present. For abdominal, no palpable organomegaly or lump were palpable. So, provisional diagnosis or after.
Okay, let's go to your examination. Look, Smith, I've
Yes,
got,
sir.
I mean, I don't agree with the examination in a lot of ways. The patient already has gangrene. What are you going to do with Burgess angle and the guttering of the veins and all that kind of thing? He already has an established gangrene.
Yes,
All this
sir.
Burgess gangrene is for impending gangrene,
Okay.
right?
Hmm.
Okay. Shiny loss of hair, muscle wasting
Loss
seen
of hair on the
in
dorsum of the
bilateral
foot,
calf.
isn't it? Dr. Smith,
Yes, sir.
you have mentioned loss of hair on the dorsum of the foot. Usually there will not be much hair on the dorsum of the foot. It is in the lower part of the leg, isn't it?
Okay.
And somewhere you have mentioned brittle nails over bilateral lower foot. What is that term? Huh?
Now, is
Name,
it
what is
wet
it?
gangrene or dry gangrene?
Dry gangrene.
So you say that there's no foul smell. Is there smell?
No, sir.
Is the line of demarcation very clearly seen?
Yes,
Okay,
yes,
you
clearly,
written
sir.
it. Okay.
Uh,
Next slide. Capillary fill time, venous filling time, guttering of veins. For left limb, you can do. Right limb is not required. It already has gangrene.
okay.
Next slide. Cold up to right mid thigh.
Okay.
Tenderness where? No
It is not
tenderness
tenderness.
seen where?
But it is not seen, it is felt. Huh? Tenderness is a palpable finding,
That is
isn't it?
right. Okay. Yeah. Yeah,
It
yeah.
cannot be
No
seen.
tenderness where? On the nose, on the scalp, on the leg, the right hand,
On the
left
right lower
hand,
limb.
back. Yeah, so where are you interested in tenderness in a lower limb?
In
In this
dorsum of the
case,
foot.
why? Why should there be
Because
tenderness? Why should you mention do you think there'll be tenderness? Unless there's some inflammation, there's some pus there, or there's some
no,
infection.
sir.
Why should you mention no tenderness?
Okay.
Look, पूरा एहसास को कॉपी करने का जरूरत नहीं होता है. You have to use your brains also, na? Dry, hard, shriveled, grind, throat extending. Okay, that's fine. Loss of sensation. What kind of sensation? Pain, touch, temperature, joint movement, joint position, vibration. You have
Loss
to
of all.
tell us everything. You have to mention everything.
Okay.
Minimal movement get at metatarsophalangeal joints.
Metaphalange.
While movement, metatarsophalangeal other toes and normal range. Tone and power of lower limb muscles, lower limbs. Okay, the whole limb. Okay, next slide. Capillary fill time, venous girth of limb, cross. Why did you have a cross leg when the thing is not palpable at all? Futile, waste of time. No lymph nodes. Which lymph nodes?
Inguinal.
So mention it.
Okay.
Next. Look, Smith, you
Dr.
don't.
Smith, can you tell when you do Fuchs test or cross leg test? Dr. Smith.
When the popliteal artery is not palpable, means by direct
Yeah.
method, where
Yeah.
the guts of the muscle is very much.
Yeah, when already sir has pointed out, isn't it? When you expect occlusion at the level of popliteal artery, you expect cross Fuchs test to be positive.
So
Isn't it?
Look.
Then there is no oscillatory movements. Already we have done palpation of the peripheral pulsations, isn't it? So there is no pulsation felt beyond the femoral. Femoral is also not felt. So where is the question of telling Fuchs test negative? It is expected. It is understood that Fuchs test will be negative, isn't it?
Yes, sir.
Next slide.
And one more
Next
thing. One
slide.
more thing. Palpation of
Yes,
peripheral
sir.
pulses. You have mentioned femoral artery pulsation are not felt bilaterally, isn't it? And you have shown the picture of the patient. Patient looks asthenic. Isn't malnourished? Patient looks malnourished. Can you try to feel for common femoral, common iliac artery pulsation and external iliac artery pulsation in this patient? And if so, where to feel for that? Them.
For common iliac artery at the level,
Yeah,
the periumbilicus level, at just left side. While iliac artery, just at the level of inguinal region, 2 centimeters above the mid-inguinal point.
Oh, there's
Dr.
a specific
Smith.
surface marking. There's a specific surface marking for external iliac artery and common iliac artery. The surface
Where does the
marking is
aorta divide? Where does the aorta divide into two?
Yeah.
Into the common iliacs?
At the level of T10.
And where's that?
Surface
At
marking,
the
surface
level
At
of
the
marking.
level of umbilicus.
Right. So now you answer this question. Where can you palpate the common iliacs?
Surface marking
Umbilical.
you have-
Even
See
the
where
aorta can be palpated sometimes in 10 patients.
The surface marking,
okay,
as you
next.
know, aorta divides, isn't it? Bifurcation of aorta, it occurs around 2 finger beds, or you can say 2 inches below and to the left of the umbilicus. That is surface marking, isn't it? From that point, you have to draw imaginary line, arbitrary line, joining bilateral mid-inguinal point. Arbitrarily, bilateral mid-inguinal point. So proximal 2/3 of that will be your common iliac, distal 1/3 will be your external iliac. Because internal iliac will go inside into the pelvis. So many a times, in case of thin built individuals, you will be able to feel for those pulsations. If at all they are palpable. If they are blocked, you will not able to feel it. I think you would have tried in this patient to feel for
Yes, but it
common
was not.
external iliac. Isn't
It
it?
was not possible.
Dr. Smith,
Yes, sir.
how will you assess muscle wasting?
By taking the girth of the
Clinically, how will you assess the muscle wasting? There are certain points in your examination. That's why I'm asking. And how you described dry gangrene? How it is classically described? It is
dry, stable,
word and mummified.
mummified appearance.
What you used? Hard. Hard is not in the classical description of the dry gangrene. What is gangrene by definition?
Macroscopic, that the tissue with putrefaction in situ.
With putrefaction
In situ of the tissue is known as dry
in
gangrene.
situ or superadded? What is classical description given in a standard textbook?
Superadded putrefaction.
Yeah. Superadded putrefaction. What are the types of gangrene?
Dry gangrene, wet gangrene.
One more. These are basic questions. Smith, these are the basic questions. Then where to palpate dorsalis pedis pulsation? Against which bone?
Dorsalis pedis is palpated against the navicular bone. We have to tell the
Navicular
patient.
or head of the first metatarsal? Which one is correct? And justification. Then posterior tibial artery against which bone?
Posterior tibial artery is palpated against the calcaneum.
Then
On the
anterior
medial side of the
artery.
ankle. Anterior tibial artery against the end of the tibia between the two malleoli.
Against lower end, upper
Against
end.
lower end of tibia.
And popliteal artery in supine position, in prone position, against which bone?
In supine position, it is palpated against the upper part of the tibia, and in prone position against the lower part of the femur.
Don't do mistakes in such basic questions. In PG exam, they definitely ask this basic question.
Yes, sir.
Okay. Continue, sir.
Yeah. Okay. Next slide. Okay. Bruit where?
Bruit at the paraumbilical region, at the level of the common iliac, internal iliac, and at the level of femoral. Because it can be a
Next
stenosis
slide.
or the occlusion.
Next slide. You have not examined his back. You have not examined his genitalia. He's got ED. How can I should be sure he's got no other problem there? Smith, look, you don't have to do a lot of work in getting a. If you have a patient of peripheral vascular disease, the most important thing is to find out whether it's an arterial, venous, or a neurogenic, right?
Yes, sir.
By history and examination. Then by your this thing, you have to find out what is the cause, and then what is the effect of your arterial disease. So how do you do? What kind of limb is this? What is critical limb ischemia?
When when there is a rest pain when there is a rest pain with ABPI less than 0.5 or
There's nothing
ankle
called
pressure.
ABPI here. No ABPI here.
Again, you are altering all the
Did you take
statements.
Did you take
What is
ABPI in your
critical limb
patient?
ischemia?
Did you take
Straightforward
ABPI in your patient?
definition.
I have tried to take, but it was not means as the
No, why did you
mono
try? Why did you try? I won't have tried. In your place, I would have said I didn't try. Why? The patient already has gangrene here. What are you going to do with ABPI? So now tell me, what is critical limb ischemia? What is the importance of this? It's called critical. Why? So
when
what?
there is the loss of the tissue or the gangrene, it will known as critical limb
So there
ischemia.
is chronic ischemia with rest pain with gangrene. The importance is that if you don't manage this patient, the patient is going to lose his limb.
Yes.
That is why it's critical. Now, what is pre-gangrene?
When there is a signs of the ischemia present in the patient, if not managed properly, then can lead to ischemia or gangrene.
No. The patient already has ischemia. If you don't manage it now, he'll get gangrene.
So it will, yes.
Now, what are the features of pre-gangrene now?
Change in the color, pulselessness, change in the temperature.
Don't beat around the bush. There's just three things. He has rest pain, right? So the artery is gone. He has hyperesthesia, so the nerve is getting damaged. And he's got edema, so the vein is also getting damaged. And the lymphatics are getting damaged. So that is pre-gangrene, right? So both his nerve is gone, his artery is gone, his lymphatic is getting infected, and his veins are getting affected. So that is pre-gangrene, right? Okay. So how do you manage this patient now?
First, I would like to do the investigation of this patient to diagnose, means to know the level of the occlusion. I will like to do the.
Hang on, Smith. Level of, you don't even know whether it's you're not 100% sure it's an arterial disease or venous disease. You have to look. It is clinical examination is not an objective examination. It's a subjective. We need some hard evidence, hard facts to prove it. Now, what are the hard facts?
I would like to diagnose diagnose for this. I would like to do the duplex scan or CT angio for this patient to confirm my diagnosis.
No, hang on. I'll do duplex or CT angio. Now, what will he do? Or means what? You give the patient a choice, or you give your junior a choice. चल duplex करा ले या CT करा ले. Whatever you want. Is that how things work?
No, sir.
Yeah, then tell me, what will you do?
I would like to do a CT angio for this patient.
Okay, tell me the indications for CT angio in this patient.
As this is above the infracrurals, above the inguinal level.
How do you know? How do you know it's above the inguinal level? How do you know it's above
Because
the inguinal level?
the patient has the buttock pain. Importance. It is pointing towards the Lariat syndrome. So it might be having the air to iliac
No.
joint.
Hang on. Is it proved? Is it proved that he's got larynx? How do you know he has? You asked 50 people out of 40 of them, 40 will say they've got some ED. A normal young man will come and say he's got ED. You label him as larynx. All this is coming because your answer is wrong. Why should you get a CT angio? CT angio is done only when you need some intervention. Are you going to intervene with this patient just now? First, get your diagnosis correct.
I will to confirm. Yes, I would like to first confirm it.
So, how will you confirm?
By duplex scan.
Yes. Okay. Now, what is a duplex? Sir, please. Dr. Manjunath, sir.
Yeah, Dr. Smith.
Yes, sir.
Tell me, what do you expect in a duplex scan?
Duplex scan is a B mode plus Doppler ultrasound. B mode shows the anatomy of the vessels. if there is any block thrombus formation or any calcification inside the due to B mode, while the Doppler shows the Doppler shift which helps us to know the phasicity of the flow direction, flow velocity.
Yeah, you want to know the level of occlusion, extent of occlusion, velocity of the blood flow, isn't it? Distal runoff
Yes.
and development of collaterals. All of these are the things what you want to know in case of duplex scan. And depending on that, if you are planning for definitive vascular intervention, definitive vascular surgery, interventional vascular surgery, at that time you can go ahead with CT angio, as sir has rightly pointed out. Isn't it? Don't directly
Okay,
jump for
Smith.
CT angio. Don't directly jump for
Smith.
CT angio.
Right. Smith,
Yes, sir.
what do you look for in duplex scan? What do you look for in duplex scan? What is B mode and what is M mode?
Uh, due to standard ultrasound, it shows the hypoechoic and hyperechoic uh, colors, which shows
Hyperechoic colors. What is that?
means
Look, Smith, just keep it simple. You've seen a
okay.
Doppler and a duplex.
Yeah.
One tells you the anatomy, one tells you the
Hmm.
physiology, the flow,
Visually.
right? Anatomy you have to see outside the vessel wall, within the vessel wall, within the lumen,
Hmm.
right? In flow you have to see at the amount of flow, which are the various, what is the length of the obstruction, how many sites are there of obstruction, which are the sites, there can be multiple sites, what is the length of obstruction, right?
Yes, sir.
Right? So you have, that is what is duplex. So you got the duplex scan here?
Yes, sir.
Yeah, just show it to us. So what is this monophasic, biphasic, triphasic? What is all this?
In triphasic, there are the three waves which are seen. In the first wave, there is the upright wave due to systolic. Second wave is due to the early diastolic wave, which is a downward flow, and the third wave, which is the upward flow, it is due to the late diastolic flow. While in biphasic, there is the loss of
No,
the
the third is because of the springing of the vessel wall.
okay,
Okay.
sir.
Okay. What is the normal
In
flow
biphasic,
in a? Okay, hang on. What is the normal flow rate in the aorta or in the femoral artery?
normal
How
flow
fast
rate,
does the blood move?
sir, I don't remember the exact value.
So it is about 35 to 55 centimeters per second.
Also, yeah.
Now suppose your Doppler says it is 65 centimeters per second or 70 centimeters per second. Are you happy or what?
Uh, uh,
What does that tell you?
there is some stenosis.
Right.
Stenosis in the vessel, not more than 50%, because if it is double, then it will be more than
Very good.
50%.
Very good. So it's less than 50%, right? Of the
Yes.
surface area.
Yes.
Because it's more than that, the flow rate comes down.
But,
Why does the flow rate increase when there is stenosis?
because the lumen decreases. To propel
What is
the
that law
blood,
called? What is that
Bernoulli's
law called?
principle. Bernoulli's principle.
Not Bernoulli's. Bernoulli's is for lift. This is Poiseuille's law.
Okay, poison.
Poiseuille. Okay, yeah. So, okay, just normal flow direction, reduced velocity, monophasic spectral waveform in tibial and dorsal pedicels, minimal atherosclerotic changes, tibia. So you got normal flow direction, reduced velocity, monophasic spectral flow in both common femoral profunda. Okay, right.
So it shows the obstruction above the level of common femoral. So it has monophasic wave.
Okay. So, Professor
Dr. Smith, are
Manjunath.
you taking the reports of bilateral lower limb or is it only affected right lower limb you are telling?
It's a two
No, it's
limbs.
outside
What is? So there are similar findings in the both the lower limbs?
Yes, sir.
Similar Doppler ultrasound findings?
Yes, sir.
Okay.
So why did the right limb get gangrene and the left not?
Due to the collaterals.
Okay.
There
Next.
may be better
Okay,
development
done,
of
doctor.
collateral than the lower limb. Okay.
Okay. Did you, what is arcus senilus?
Senilus.
What are the stigmata of atherosclerosis?
Uh, Arcus senilus is
Stig-
seen in the old age in the eyes.
Okay. It happens in this. What is xanthelisma? Does he have xanthelisma?
No, sir. Clinically, it is not seen in dental.
Right. You have to mention all this because there's a
Okay.
markers for global atherosclerosis. Okay, so you just have to mention it.
Okay, sir.
Okay. Sir, please, anyone. Yeah, Professor Rohit, sir.
Dr. Smith, please.
We can't hear you, sir. Yeah, please.
How do you want to proceed with this Dr. USG report? How do you want to proceed?
As as is the block is below the level of the common femur, I would like to further confirm it where it is at which level, which level of the aorta it is there. So I would like to confirm it with the CT angio or digital subsection angiography to further intervention for this patient. And for intervention, I would like to do the aorto bifemoral bypass grafting. After
Hang
seeing
on. Smith.
Yes, sir.
What is task 2 guidelines? What are task 2 guidelines?
Task 2 guidelines. Task 2 guidelines divide the air to iliac blockage or occlusion into 4 types. At which level it is that blockage, how many it is occlusion or stenosis, and then according to the classification A, B, C, or D, it guides you to do the intervention. If it is A, you would like to progress with the endovascular treatment. If it is D, you will do
Very
the
good.
surgical treatment.
Very
Why
good.
this
Very
D?
good. Hang on. Very good. So why did you straight away go for a bypass surgery?
That means I would like to confirm
How
it
did
is
you
a
decide?
complete occlusion.
Now,
Means
how did you decide that this patient needs bypass and not an endoscopic? You could put a stent through it. You could put. Why did you go
means
straight away?
I would just like to first confirm how it is complete occlusion, at which level it is, or it is just a
Exactly.
stenosis.
No, hang on, Smith. That is why you can't just jump.
Yes, sir.
Sir, Professor Singh.
Yeah. So you want to plan for some definitive vascular surgery? You mean?
Yes, sir. I would like to do some
You want to
some
proceed,
type of
you want
surgery.
to proceed with angiography, isn't it?
Yes, sir.
You want to proceed with angiography because you want to plan some vascular intervention.
Yes, sir.
What are types of angiography you know?
Digital subtraction angiography.
Yeah, they can be conventional angiography. What is done by the classical cell division technique, or recent advances like DSA, digital subtraction angiography, CT angio, MR angio, isn't it? And nowadays the CT angio is available everywhere, isn't it? I hope you have got done CT angio in this patient.
Yes, sir. I have done it.
Can you know the report? Okay, please.
Yes.
So all the films of CT angio?
Yes.
Can you tell us the findings?
In this, the arch of aorta, ascending thoracic aorta is seen below at the level of till renal vessels. It is seen completely below infrarenal. The aorta is not seen, most probably due to the occlusion or athorma. Till by common iliac vessels are not, iliac arteries are not seen. External iliac and internal iliac are not seen. While from the suprafemoral artery, it is seen completely till lower limb. And the collaterals are developed from suprarenal till the superior femoral arteries between. Yes, sir.
Yeah. I think there is a good amount of blood flow, even in the distal part of the extremity, isn't it?
Yes, sir.
Maybe because of development of collaterals.
Collaterals, yeah.
So how do you plan for the treatment?
As there is the complete occlusion below the infrarenal level, common femur, common iliac and external iliac, I would like to do I would like to do the surgery better than the endovascular treatment, as it is come into TSC to D stage. So I would like to proceed the aorto bifemoral bypass, as patient has no any other comorbidities. So I can do the aorto bifemoral, or I would like, if patient were minimal operative, means minimal risk, I would like to do the
ऐसे और
axillary femoral.
दिखाऊं तो वो मत दिखा रहे भाई.
Sorry, sir.
हाँ, इधर है.
I want to add something. Whenever these questions come to you, what do you?
So we can't hear your voice
Now I'm audible, sir. Hello. Now
very
I'm
faintly, sir. Very faintly.
Hello. Now, sir.
अभी ये पीवीडी वाली कट रखो. हाँ,
Okay, Smith. Till
yes,
Dr.
sir.
Rohit is
हाँ,
what
mix मत करो.
till you do
Sir,
this surgery,
right,
what treatment
side
will you
में
give to
रखो.
this patient?
हाँ, रखो.
He's in
Sorry, sir.
pain.
I can't.
This patient is in pain. He has breast pain. He has gangrene. Till you do his surgery, what is the treatment plan for you?
We are going to.
I would like to.
surgery.
I would like to continue the medical management. That is, I will give the patient the developmental antitherapy. That is aspirin, clopidogrel.
Yes.
I would like to start the statins in this patient. I would like to do the to decrease the pain. I will do the NSAIDs or tramadol.
Electronic projector select exam.
Look, you
Now
have to
I am audible,
manage his
sir.
pain. Yes, sir. Very much, sir.
Dr. Smith, whenever these type of questions are asked
Very important
from you
to
in the
clarify the
exam,
topics after
you should always give the answer, especially in the management.
Are here in this session.
There should be a stepwise approach to manage these patients.
This video is available.
These type of patients, first
and
you
it-
have to
For mistake,
control the risk factor.
try to
Then you will answer like that. There, what are the medical therapies? Then you will evaluate these type of patients for revascularization or bypass. Then you will take care of local care of the dry gangrene in this case, as in this case, and then rehabilitation and follow. In this, you should always answer in this stepwise manner. Okay.
Okay.
And what are your goals? Goals of, in this goals of treatment in these patients?
First primary goal is to, as there is the blockage, occlusion in this, I would like to do the revascularization, and I would like to decrease the pain of this patient. Secondly,
Smith, hang on. Suppose you were this patient, you had this problem. What is your primary aim? You want to get rid of the pain. You want to get rid of that gangrene, right? Pain is most important. Breast pain is a very debilitating condition. You have to manage it, right?
Okay.
You have to assess whether this thing is only involving the limbs or elsewhere.
Okay.
The heart, the brain, right? You may manage this and he dies with a heart attack, or he dies with, he gets a stroke. Then, so all this is important. Then you have to assess what kind of revascularization can you do, right? You have to prevent this from becoming worse. You might revascularize, and if the patient will get a obstruction elsewhere, right? And you have to follow. So these are your goals. You get me?
Okay.
Sir, please, Dr. Rohit.
Sir has explained you very, very well that your primary aim is to relieve the ischemic pain, and along with that, preservation of the link function and prevention of the cardiovascular events also, so that you treat this patient completely. Okay. And in medical management, what are the pharmacological agents that you can use in these patients?
First, I would like to start the dual antiplatelet drug, that is aspirin, clopidogrel, to prevent the further atheroma or plaque formation. And then, secondly, I will start the anti-hyperlipidemia drugs, that is statins. Then I like the patient to stop smoking, as he is a chronic smoker. So it prevents any further damage. Then I would like to start the silastazole, which is the PDE3 inhibitor. For pain management, for pain elevation, I would like to start the N6, or if still further he has pain, then I would like to switch over to tramadol. Or if not possible by that also, I would like to switch over the opioids.
Is there any contraindication for using silastazole where you cannot use it?
Patient is having headache or any heart means
Having
any
cardiac, yes.
cardiac condition.
Yes. Good.
Dr.
And,
Smith, in a
yes,
such a
sir.
condition of chronic ischemia or chronic arterial occlusion disease, your treatment actually should start from some lifestyle changes, modifications, isn't it?
Yes, sir.
Like asking the patient to stop BDs. Already you have started some medication, then you are asking the patient to stop BDs. It should not happen. No, first you should advise lifestyle modification. Simultaneously, you can start medical treatment.
Yes, sir.
Isn't it? And you told statins. Why statins? What is the role of statins here?
It is due to the
Do you want to give it
in the
blindly?
pathophysiology. Sorry, sir.
Do you want to give it blindly, or after any investigation you want to start this?
I would like to do the cholesterol lipid profile, sir.
Get lipid profile done. If there is any evidence of hyperlipidemia, then you want to give statins, isn't it? If a lipid profile is within normal limits, there is no fun in giving that, isn't it? What are the other drugs given to improve the vascularity, medical treatment?
Sir, silastazole. In some cases, pentoxifylline.
Pentoxifylline. Yeah, you should know the mechanism action of these drugs. Okay, how pentoxifylline acts,
Yes, sir.
how silostazole acts. Can you tell us the mechanism action of pentoxifylline?
It is a PD5 inhibitor.
Pentoxifylline. I feel pentoxifylline is a rheological drug. Rheological drug means it acts on the RBC to change its shape so that the RBC can pass through narrow size vessel. Isn't it? It acts on the RBC so that they can change their shape and pass to the narrowest size vessel. That is the meaning of rheological drug. And how does the silostazole acts?
It is a PD3 inhibitor.
Phosphodiesterase 3 inhibitor, thereby causing increased vascularity. Very good. Any other drugs? Some xanthine oxidase inhibitor? Even you can give some antioxidants also. Even antioxidants have got some role, isn't it?
Okay, sir.
Antioxidants, very good. So first lifestyle modification, then medical treatment, then comes the role of surgical treatment. There is no emergency surgical treatment in a case of chronic vascular insufficiency, unlike a case of acute arterial occlusion, where there is a role of emergency vascular intervention, isn't it?
Yes, sir.
In this case, already you know that there is development of collaterals, isn't it? And there is gangrene of only distal part of the great toe, not forefoot or whole of the foot. Nothing, no need to worry or no need to hurry to do definitive vascular surgery in this patient, isn't it? Okay.
Yes, sir.
What are types of amputation you know, Smith?
From starting below, at the level of the metatarsophalangeal joint, race amputation, then spine amputation, pass amputation, seams amputation, below-knee amputation, above-knee amputation, then hindfoot amputation, and in upper limb.
No, you limit to lower limb. You limit yourself to lower limb. Okay.
Yes,
In this patient, is there any role of amputation?
No, sir. I will first I would like to start the medical treatment. Then I will with lifestyle medical, and after the surgical, I would like to wait for some time to increase the flow. After some times, I would like to do the amputation. If I
No,
will
Smith, hang on, Smith. He's got a line of demarcation.
It will auto amputate later on.
So what are you going to wait for? You think your revascularization will make that thing live?
No, sir. It wouldn't.
Then? So what kind of amputation will you do here?
Raise amputation.
Huh?
Raise
What is raise?
Amputation at a level of metatarsophalangeal joint, where the head of the first metatarsal is amputated with the proximal and distal phalange.
Okay, what are the principles of amputation? Basic principles of lower limb amputation. Now that question's been asked, let's ask you about amputation.
When there is no blood supply, or when there is means how to do it means
No,
sorry, sir,
basic
you can
principles.
repeat.
Basic
In lower limb,
principle.
what are the basic principles?
Okay.
The posterior flap will be longer or the anterior flap will be
Okay,
longer.
posterior flap will be longer.
Why?
Because if we give the patient the prosthesis, it will better fit, and there will be no necrosis or pain in at the prosthesis and the stump.
No, hang on. Just what did he say? Why is the posterior flap longer?
It has first, it has the better blood supply.
Why
Than the
does it
anterior
have
one.
better blood supply? Why does it have better blood supply? Extensors, which are anti-gravity muscles, are stronger and they have a better blood
Okay.
supply. So posterior, this is one. What is the other reason why the posterior flap should be longer?
It will fit adequately with the prosthesis. So there will be no pain or any
No.
pressure over the.
No. When you bring the posterior flap longer, it comes, the anastomosis or
Anterior.
the line is on the anterior, so that the patient can see.
Okay.
Right? He can see. If it's in the posterior, he can't see his stitch line. And if it breaks down, he doesn't know. If it's anterior, he knows. Right? Okay. What are the other principles? One is for the flap. What are the other principles? What is the ideal length? Below knee, above knee?
For below knee, it must be more than 8 centimeters from the tibial tuberosity. Ideally, more than 12 centimeters.
There's no more than 8. More than 8 can be 25 centimeters also.
8 to 12 centimeters, ideally.
Why that much?
Because that much length is needed for to fix with the prosthesis, means to keep the stump with the prosthesis, and patient can walk better without any external help.
Suppose his lower leg, I keep it at 5 centimeters and I keep it at 12 centimeters. What's wrong? Which will you prefer? A 12 one or a 5 one or a 8 one?
12
Why?
one.
What is the ideal length?
8 to 12 centimeters.
Why? What is the ideal length? What is the principle behind ideal length?
Because if less than that kept, patient can't do movements at the knee joint. It will be difficult, or
If it is very long, if it is
bearing
very
will
short,
be.
if the prosthesis is very short, the principle of mechanics, the pivot will be right below. So it will come off.
Okay.
Right? If it is very short, the knee joint there'll not be enough suction inside. Right? Below knee amputations, patients can walk without a stick.
Yes.
There was that dancer that I'm forgetting her name. She used to dance with a prosthetic limb.
Right?
Above knee, they always need a stick.
Okay,
I think.
What are the options for endovascular intervention?
I can go with the percutaneous transluminal angiography. Then I can do the balloon angioplasty, and then go with the stenting.
Yes. Okay. And what are the success rates for endovascular intervention over the bypass? If you do these stentings, what are the success rate means 5-year patency we see in these patients?
5-year patency is around 70%.
Yeah, it is nearly 80%, more than 80%. Okay. And what are the contraindications to these endovascular repairs?
If there is the occlusion more than 5 centimeter in the common femoral, I mean in the common iliac, or it is involving the aorto and iliac level, whole whole vessel is involved, 100% occlusion is there, it is contraindicated.
And poor
if it-
distal runoff.
Oh.
Dr. Smith,
Yes, sir.
what is ideal amputation stump?
Sir, for DK or DK?
What is ideal amputation stump? This is again very commonly
Okay.
asked question.
Ideal amputation stump, it must be a conical in the shape. There will be a no scar at where the prosthesis is kept. There will be no infection, no abscess formation, or any.
Dr. Nishkant, sir.
Okay, I will give two scenario. In scenario number 1, age of the patient is 50 years with a bilateral aortoiliac obstruction. What is treatment plan? In second scenario, patient age is 80 years with bilateral aortoiliac obstruction. How will you manage? Which bypass you will do?
In case of 50-year patient, I would like to do the aorta bifemoral bypass. While in case of the 80-year, he cannot. He might have comorbidities. He cannot sustain that long surgery. So I will go with the axillary femoral bypass with femoral crossover.
Okay.
Dr. Nishkant, sir, can you close here, sir? It is 9:20 already.
Yes,
One
sir.
more
Yes,
thing
sir.
is there.
Yeah,
Yes,
please,
sir.
One more
please.
thing
I
is
think
there.
Dr.
Thyroid
Smith,
testing.
Dr.
Yes, sir.
Smith, there were somewhat more mistakes in the presentation. But don't worry, this is platform to do the mistakes and learn. This platform is for the rehearsal of exam. We are here to correct your mistakes. This video is available on YouTube. Go through it and look for mistakes you have done and try to overcome it.
Okay, thank you, sir.
Okay, well done. Well done, Dr. Smith.
Yeah,
Keep
Smith,
on
I think you've
improving.
done very well. Certain
on
areas
improving.
were lacking, but overall, brilliant performance. Very well done.
That is his habit, sir. That is his habit. He takes everything very casually.
No,
Yes.
as a surgeon,
Yes, sir.
look, as a surgeon, you got to be very careful about your if you do a surgery like this,
In
the
3 years,
patients will.
I could not change him at all.
That's something you can change most people.
Sir, frankly, 80% of the changes suggested he has not edited. He is that much lousy guy. I have taken him that you have to present the case at least once before your exam, which is 3rd, 4th November. But as if he is obliging me, he has presented. And I'm happy for that.
I think it's a very brave act to come and face
Yes.
Khunkar examiners like us.
No, it is at gunpoint, sir. It is at my gunpoint.
Yes.
We wish
Anyway,
best of
well
luck
done,
to
Smith.
Smith, sir. Best
Yeah,
of luck
best
to
of
Smith.
luck.
Best of luck, Smith.
Best of
Thank
luck,
you, sir.
Smith.
Thank you, sir, everybody. Thank you.
Next candidate, Dr. Lalit.
Sir, good evening, sir.
Start presenting the case.
Share பண்ணுங்க. Unmute பண்ணுங்க. Share. Share பண்ணிட்டியா? பண்ண முடியாது.
Dr. Lalit, are you here? Please unmute yourself, Dr. Lalit.
Sir, yes, sir. Just a minute, sir.
Please switch on your video. Please enable your video, Dr. Lalit.
Video. Sir, yes, sir. Green, sir.
Yes. Please follow the instructions, PG, dear sir. Just shut down all the things
Yes,
in the window. Press the share
Yes,
screen
sir.
option. What you are getting?
Yes, sir. The photo,
What you are
image,
getting, I'm
profile,
asking.
document.
What you are
This is
getting?
option. Photo, image from file, document, web URL, screen, camera.
You are using a Windows, right?
Yes, sir. Windows only.
Press the screen option.
Yes.
Okay, now you please open the PowerPoint. Minimize this window. Yes, correct.
Yes.
Yes, make it to slideshow. Present to a meeting. Yes.
Yes, sir.
Okay, don't worry, my please advance the slides. Cancel this. All these things are not doable now. Yours is not a window. I
Yes,
think
sir.
it runs on Google. No problem. Please cancel this and start your presentation. Move the slides with this only. Introduce yourself, your
Yes, sir.
unit chief, HOD sir, and then start your presentation. Faculty, please take over, sir. Sorry for
So
the
good evening, sir.
inconvenience.
Good evening, sir.
Lalit, please switch on your
Lalit,
video.
second. Yeah. Sir.
You start your presentation, Dr. Lalit.
Yes, sir. Yes, sir. Sir, good evening, sir. Dr. Lalit, second year postgraduate from
We are
Chitram Medical
unable to
College
see
and
your
Hospital, sir.
PowerPoint, doctor. You just open the PowerPoint slide, Dr. Lalit.
Yes, sir. I've opened it, sir.
Just start your presentation and completely finish your presentation. We are unable to see you, but don't do anything now.
Okay, sir. Sir, some Dr. Lalit, sir, second year postgraduate from Chitram Medical College. HOD Professor Dr. Anantaramakrishnan, sir. My unit chief is Dr. Prabhakaran, sir. So this is the patient's general condition. Patient is Ms. Mehtaj, 48-year-old female. She is a homemaker by occupation. She is from the area Tirupattur in Tamil Nadu. So history, sir. A 48-year-old female, Mrs. Mehtaj, came to the OPD with chief complaints of swelling in front of the neck for the past 1 year. History of presenting illness. Patient was apparently normal 1 year back, after which she developed a swelling in the anterior aspect of the neck, which was insidious in onset, started as a small swelling and gradually increasing in size to attain the current size. It was not associated with pain. History of weight gain was present. No history of constipation, no history of cold intolerance, no history of fatigue, no history of such symptoms suggestive of pressure, no history of pressure
खुल के रखना
symptoms,
नहीं है भाई,
no history
दूसरी
suggestive.
जगह रखना, हो जगह उसका दूसरी जगह है.
Sir, sir, may I continue, sir?
Yeah, go on, please.
So no history suggestive of hypothyroidism. So past medical history, patient is a known case of hypothyroidism on tablet thyroxine 25 microgram for the past 1 year. Patient is not a known case of type 2 DM, hypertension, bronchial asthma, TB, epilepsy or CAD. No history of previous surgery and no history of prolonged drug intake. So personal history, patient consumes a mixed diet, has a normal sleep-wake cycle, has a normal bowel and bladder habits. Patient has no significant family history. So menstrual history, age of menarche 13 years, LMP is for 2 years ago, static history P3L3, last childbirth 25 years ago. summary of the history. A 48-year-old female came with chief complaint of swelling in the anterior aspect of the neck for the past 1 year, gradually increasing in size to attain the current size, with history of weight gain, and on tablet thyroxine 25 microgram for the past 1 year, and no history suggestive of hypothyroidism, and no history suggestive of compressive symptoms.
Very good, Dr. Lalit. Very good. So
Yes, sir.
start with first slide.
Yes, sir.
Go back to the first slide.
Yes, sir.
Go back to the first slide. Particulars of the
Yes.
patient. Yeah. See,
Yes, sir.
you say mention homemaker. Homemaker is not an occupation.
Yes.
Yeah,
Yes, sir.
you while presenting just mention homemaker. He's a homemaker. And because the occupation, the
Okay, sir.
meaning of occupation is they have to earn some livelihood. They have to earn some money out of it.
Okay, sir.
Okay, go to next slide.
Okay, sir.
Go to next slide, please.
Yes.
Complete slide. Next slide.
Yes, sir.
Chief complaints. Yeah. So here you have mentioned in history of presenting illness, swelling on the anterior aspect of neck,
Yes, sir.
isn't it? So don't mention medical terminology
Yes.
in history. History should be in patient terms. In chief complaint, you have mentioned
Okay,
correctly.
sir.
Swelling in the front of.
Yes, sir. In front of the neck. Sir, am I audible, sir?
Yes, you are.
Neck.
Yes, sir.
Sir, in this, I have some problem, one objection. Actually, history
Yes.
is the doctor's interpretation or the surgeon's interpretation of what the patient is saying. So he can use terms
Yes, sir.
like hypothyroidism and thyroxine.
Yes.
All this can
Yes,
be
yes, sir.
used.
Symptoms suggestive of hypothyroidism, symptoms suggestive of hyperthyroidism, they can mention. They can mention, sir. And you have mentioned swelling to start with. Go back to previous slide. History of presenting illness. Previous slide. Dr. Lalit. Yeah.
Yes, sir. Yes, sir.
Yeah. Swelling to start with. What was the size of the swelling to start with? Previous slide.
Sir,
Previous slide.
patient didn't give. Sir, now,
You
sir.
have mentioned that it has increased in size to attain current size, isn't it?
No, you can ask the patient and
Yes,
say
sir.
as gestured by the patient.
So what is the current size? What is the current size? Approximately.
You can't just
what is
say-
the current size?
Sir,
What was the size when she has first noticed it? Isn't it? So that we can imagine something
Yes,
in
sir.
our mind. When patient has first
Yes, sir.
noticed the swelling, what was the approximate size and what is the approximate current size? You are not getting any idea, isn't it? You are just mentioning
Sir.
current size. What is the current size?
Yes, sir.
History-wise.
Even if the patient doesn't mention, you can ask, what was the size when she noticed it first? And then say as gestured by the patient. You just can't leave it blank, no? Small swelling, increase to current
Yes, sir.
size.
One more thing, next slide.
Okay,
Next
sir.
slide, please. You did mention there is history of weight gain, isn't it?
Yes, sir. Yes, sir.
There is history of weight gain. How much history of weight gain is there?
Sir,
Isn't
she says
it?
6 kilos in 1 month. Yes, sir. 6
You
kilos
mentioned-
weight gain, sir.
you
From
mentioned it.
54 to 60 kgs. Sir.
Yeah. You mentioned it. About 6 kg weight gain is there in a period of 6 months or 1 year, whatever it is.
6 months.
It could be significant
Yes,
weight
sir.
gain, which is suggestive of hypothyroidism. Because already you know that patient
Yes,
is
sir.
on thyroxine medication.
Thyroxine.
Right?
Yes, sir.
So when already patient is known case of hypothyroidism and patient is on thyroxine, why you want to rule out a history of suggestive of hyperthyroidism? You did mention that negative history, isn't it? There is no history suggestive of hyperthyroidism.
Yes, sir.
Is it
Yes, sir.
necessary in this case? If so, why? How it is
So,
important?
sir, if the patient if it was a multinodular goiter, that can
Yeah.
become secondary thyrotoxicosis, sir.
No. In this case, there is possibility of drug-induced thyrotoxicosis, isn't it? If you don't titrate the
Yes,
dose
sir,
of
but,
L-thyroxine with some thyroid profile, isn't it? There is possibility of
Okay.
iatrogenic.
Yes.
Is it drug-induced? If you are giving more dosage of thyroxine without seeing the report of thyroid profile, you may cause drug-induced hyperthyroidism. That is possibility in this case, isn't it?
Okay, sir. Yes, sir.
And don't tell too much of negative histories. And don't tell too much of negative histories.
Dr. Lalit,
Yes, sir.
at
Yes,
the
sir.
end of the history, what is important? regarding your presentation, how you are giving, exploring or excluding differential diagnosis. Suppose case of the thyroid. Patient presented
Yes, sir.
with a swelling on the anterior aspect of the neck. So which is more important in this condition? How you are exploring the history? There is no sudden increase in size or decrease in size of the swelling. Then there is no symptoms suggestive of thyrotoxicosis. There is no symptoms suggestive of the hypothyroidism. There are no symptoms suggestive of malignancy. There is no symptoms suggestive of drugs intake. Or there is no symptoms suggestive of your menstrual history, oligo. All these points are very important in negative history. There is no mark for diagnosis. There is mark for differential diagnosis. And in by negative history, we can assess your spectrum, how you are excluding all these negative points. That is more important.
Okay, sir.
What is your opinion,
Okay.
Manjuna sir?
Yes, sir. You're absolutely right. So just to go to summary slide. Summarize the history.
Yes, sir. Sir, 48-year-old female came with chief complaints of swelling over the anterior aspect of the neck for the past 1 year, gradually increasing size to attain the current size with a positive history of weight gain. Patients on tablet thyroxine 25 microgram for the past 1 year with no history suggestive of hyperthyroidism and no history of compressive symptoms.
What is she probably suffering from?
So, my guess was she suffers from hypothyroid state and some multinodular goiters.
How can you make out
Based on the
multinodular
age as
history-wise?
factors.
How can you make out multinodular goiter history-wise? You can make out diffuse goiter, isn't it?
Diffuse goiter, yes, sir.
So not yet examined the patient, isn't it? So it could be
Yes,
hypothyroid
sir.
goiter or colloid goiter,
Yes,
isn't
sir.
it? History-wise,
Yes.
hypothyroid goiter or colloid goiter, we can say. Is there any evidence of malignancy in
Yes.
history? Is there any evidence of malignancy in
Sir,
history?
no positive. No, sir. No, sir. There was no rapid increase in size. There was no associated hoarseness or change in voice. There
Rapid
was no
increase in
rapid
size
increase.
swelling indicate what? Does it indicate malignancy? Rapid increase in the size of the swelling?
So if in acute conditions, the internodular hemorrhage can also increase rapid increase in size,
No,
sir.
you're
But
absolutely right.
when it's
There is
associated with other
use these terms very cautiously. Rapid increase and sudden increase. In hemorrhage, there will be sudden increase in the size of the swelling, whereas in malignancy, there will be rapid
sudden
increase
increase.
in the size of the swelling. Isn't it? And there are no any evidence
Yes, sir.
of
Yes, sir.
spread. No evidence of spread. Either regional spread to the lymph node or
Yes, sir.
distant spread to the
Or
bony
RLM,
spread.
recurrent.
Isn't it? There are no
Yes, sir.
features of metastasis. That also we can highlight.
Yes, sir.
Okay.
Yes.
So more features wise, history wise, you can think the possibility of colloid goiter, simple colloid goiter.
Okay, sir.
Isn't it? Okay. Can
Yes,
you
sir.
proceed with the examination findings? Positive examination
Yes.
findings, please.
So this is the clinical image, sir.
Yeah. Good. Good
So
image.
should I change the slide to my examination findings or should I just
Right. Please. You go on presenting your findings.
Okay. So examination on inspection after obtaining consent in a well-lit room. Patient was examined by standing in front of the patient. Butterfly-shaped swelling of size 8 centimeter cross 6 centimeters, the anterior aspect of the neck, extending from the upper border of thyroid cartilage to 2 centimeters above the suprasternal notch. The swelling moves with deglutition. The surface of the swelling appears bosselated. Margins appear well-defined. The skin over the swelling appears normal. No scars, no sinuses. Lower border of the swelling is visible. Trachea appears to be in midline and no other visible swelling, sir. This is on inspection. On palpation, no warmth and no tenderness of the swelling. Swelling of size 8 cross 6 centimeters over the anterior aspect of the neck in the thyroid region was firm in consistency, extending from the thyroid cartilage to 2 centimeters above suprasternal notch. And laterally, the bounded by sternocleidomastoid muscle, swelling moves with deglutition. 2 palpable nodules on the left lobe of the gland, largest measuring 2 centimeters cross 2 centimeters near the upper pulsar, firm in consistency and moves with deglutition. Surface of the swelling appears bosselated, margins are well defined, and lower border is palpable. The trachea is in the midline. Bilateral carotid pulsation is felt, and there was no other palpable swelling in the neck. Auscultation, there was no audible bruit. Percussion, a resonant note over mandibular sternum, sir.
Percussion should precede auscultation, Dr. Lalit, isn't it?
Yes, sir.
Yeah.
Sir?
Percussion
Sorry, sir?
should be maintained before auscultation.
Yes, sir.
Okay.
Okay, sir. I'm saying that.
So nodules were felt only in the left
So
lobe or
summary of
right
the
lobe also?
so
Nodules were
palpably it
felt
was only on the left lobe. Sir.
There were no palpable nodules in the right lobe.
I
Because
could not palpate, sir.
looking at the picture, you could see
Yes, sir.
nodules in both the lobes. In fact, right side
Yes,
it is appearing bigger than the left side, isn't it? And you
yes,
did mention that only nodules were felt in the left lobe.
left lobe, yes.
Is it correct? Finding is correct?
Sir, because on left, when I palpated the patient, it was more prone on the left side, sir, than on the right side.
Whether
I could
nodules are
elicit
there on the
more
right side or
palpation.
not?
Sir, no, right side, no, sir. It was not there, sir. We've
There are
just
no
done
palpable nodules on the right side, right lobe?
No, sir. No, sir.
No palpable nodules on the right lobe. Okay, we'll accept it. What about carotid pulsations?
Sir, but it was felt bilaterally, sir.
Bilaterally normal position or pushed backward?
No, sir, it was in normal position, sir. It was palpated at the level of the upper borders, the thyroid cartilage.
Again, which bone?
C6, sir. C6 tubercle of the C6 vertebra, sir.
Yeah. Transverse process of the C6 vertebra, there is a tubercle called a Chassagne tubercle, isn't it? Usually, we
Chassagne
feel the
tubercle.
carotid
Yes, sir.
pulsation against that. So bilateral is felt in normal position. If it is not felt, what it is called as? The bilateral carotid artery pulsations are not felt.
Berry sign is positive.
Positive Berry sign. What does it indicate?
Positive Berry sign.
What
Sir,
does it indicate?
if it's a
Positive Berry sign?
malignancy, so that carotid pulsation, the carotid either it's infiltrated or it's dislodged, sir, because of a large goiter.
Yeah. There is encroachment or infiltration to the carotid sheath. That is why carotid pulsation is not felt.
Yes, sir.
That is a sign of malignancy.
Yes, sir.
Isn't it? Very good.
Yes, sir.
What are the tests you did on this patient? Any special tests? Any special manuals?
I did the Kryles, sir, to check for nodularity, whether Kryles method I palpated, sir, on the left side.
Oh,
To confirm the nodularity.
Is it a routine to do Kryles method for palpation of
No, sir, only
goiter?
when we have doubts whether the nodule is not isolatedly palpable, that time we can do Kryles method, sir.
In case of very small nodules, when it is not able to palpate with all the fingers, at that time you use Kryles method, isn't it? So don't mention Kryles
Yes,
method in this case. It is not applicable.
Okay,
Okay. Okay. Did you
Okay,
do examination by Pigilow's method?
Physilos method, no, I didn't do, sir, but because
Why?
the swelling was visible, because it didn't look like it didn't look like a thick or a short neck, sir, and the swelling was quite visible, so I didn't do a Physilos test, sir.
Yeah, very good. Again, Pigilow's method is also not applicable for all the patients. In patients with short neck or obese individuals, isn't it? When thyroid is not better visible or palpable, at that time you use Pigilow's method. Very good. Similarly, we have to tell for Price method. Okay.
Yes, sir.
What is Lahey's method
sir.
of palpation for thyroid lobes?
So,
Left thyroid lobes.
The
Lahey's
Lyle's
method.
method usually to palpate the posterolateral surface, sir. So we stand in front of the patient and we push one lobe towards the right lobe, we push towards left side, sir, so that we can palpate the posterolateral surface of the left lobe, sir. And same for the other way around, sir.
Okay. For
Please
better
position
palpation
of patient and position of examiner.
For better palpation of the individual lobes, you use Lahey's method. Very good.
Doctor,
Yes, sir.
what is position of the patient? What is position of examiner? And which hand is used?
For Lahey's method, sir, or in general, sir?
For Lahey's method.
Sir, for Lahey's method, we stand in front of the patient, sir.
So which hand is
we
used
sit
for
at
right
the level
lobe
of,
and which hand is used for left lobe?
sir, to see the
These are the basic questions. Examiner will definitely caught on this.
So to the right lobe, we push with the left hand, sir. Left lobe with the right hand, sir.
Okay. And how to perform the classical examination?
So we stand behind the patient, sir. Stand behind the patient and we use both our limbs, both our hands to palpate, sir.
Where? What is position of forefinger
Sorry?
and what is position of the thumb? Where we have to keep the thumb and why? And why to? What is the advantage of palpating from behind? These are the basic questions.
For better palpation
You
of
have to
both the
keep
lobes
the
simultaneously,
you have to
isn't
keep
it?
the thumb on the both thumb on the occiput so as to flex and extend the neck. And with the concavity of the forefingers, thyroid gland is a better palpable.
Both the lobes can be palpated
Yes.
simultaneously, unlike in Liage method where individual lobe is felt separately, isn't it?
Yes, sir.
And for
What
thyroid
are other
nodule,
tests? What is Cocker's test or Kocher's test?
So Cocker's test is when you come in a large medullary goiter, when you push the trachea, when you push the lobe to one side, patient feels on the larger side, the patient has striders. The patient develops striders, sir.
Yeah,
The positive Cocker's test indicates in tracheal involvement.
yeah. If patient has got symptom of this strider, no need to
Yes, sir.
demonstrate this test. Already patient has got that symptom, isn't it? If you
Yes, sir.
suspect, tracheal compression later on, you can do this test.
Yes, sir.
What is the
Yes.
remarks of the test in this patient? Conclusion of Kocher's test? Is it positive or negative?
It was negative, sir. Negative,
It is
sir.
negative. Good, good. The consistency of the swelling you told?
It was firm, sir. Firm inconsistency, sir.
Firm inconsistency.
give the
Throughout,
examples of the
all
different consistencies in
throughout
different
it is
thyroid
firm?
conditions.
Sir, sorry, sir.
Give the examples of the different types of consistency in thyroid swellings.
Sir, if in it's woody, hard, and renal sterilitis, sir. If it is,
Soft.
it's extreme.
Soft consistency, in which condition you will get?
In a diffuse goiter, sir.
No. Colloid goiter.
Colloid goiter. Colloid.
So what is colloid goiter?
So colloid
What is
goiter
definition?
is when patient has. Sir,
What is
it's the
definition
last
of
stage
colloid
of diffuse.
goiter?
So the last stage of diffuse hypoplasia, sir. Prolonged, long-standing
No.
thyroid
Wait.
TSH.
What is colloid goiter? It is end result of the first stage of the goiter formation. Natural history of goiter formation. So what are the stages of natural history of goiter formation? What is stage 1,
So
stage 2,
initially,
stage 3?
TSH. So follicular hyperplasia initially, sir.
Why? Due to continuous stimulus.
So because of TSH continuous stimulation, sir. So there'll be follicular hyperplasia. So initially multiple follicles are formed, sir. With prolonged time, the TSH levels will dip
So
down.
that's why there is
So
a
those
diffuse
follicles that
goiter,
has,
and at the end of the
yes,
first
sir.
stage, all the follicles will get filled with a colloid. That's why it's having soft
Okay.
inconsistency. In second stage,
Okay.
there is a
Yes, sir.
fluctuation in stimulus.
Yes,
So
sir.
lead to the nodule formation.
Yes, sir.
And
Module
third
formation.
one is the
Yes, sir.
nodules are inactive and internodular
So
tissues
they
more
will
active.
become active. Yes, sir.
Hello?
Yes, sir. Yes, sir. Yes, sir.
Dr.
So any
Lalit,
other type
mention-
of consistency, woody
Yes.
consistency seen in?
Woody renal sterilitis, sir.
And what is normal consistency of thyroid?
Firm inconsistency, sir.
Okay.
Rubbery
So
to
see-
firm inconsistency.
Dr. Lalit, did you mention about the signs of hypo or hypothyroidism in general physical examination? Did you mention that?
No, sir, I didn't mention about those signs, sir.
Yeah. In the general physical examination, you have to mention that. If there are any signs of hypothyroidism or hyperthyroidism, or else in a single sentence, we can say there are no signs suggestive of hypo or hyperthyroidism. Okay. So that is must
sir.
in
Yes.
general physical examination. Okay.
Yes.
So can you tell your diagnosis? If all your findings are over,
So
can
it's
you tell your
a non-toxic. Yes, sir. It's a non-toxic, non-malignant multinodular goiter, sir.
non-toxic, non-malignant, multinodular goiter involving
Right.
Involving only one lobe or both the lobes?
around left lobe, sir. Left lobe of the thyroid gland, sir.
I still doubt, man. Dr. Lalit, I still doubt because looking at your picture, it appears
sir.
as if both the lobes are enlarged, isn't it? And somewhere you have mentioned it is classical butterfly shape, isn't it? You mentioned
Yes.
it,
Yes, sir.
isn't it? You have mentioned it is
Yes, sir. I
butterfly shape.
mentioned it.
That means there
Yes,
is
sir.
an enlargement of both the lobes. Then only it gives butterfly shape. Otherwise, only one
Yes, sir.
this one, only one half of the
Yes, sir.
butterfly, no, only one wing of the butterfly, isn't it? Obviously, there
Yes,
may
sir.
be enlargement of
Yes,
both
sir.
the lobes. Yeah. So, what is your provisional diagnosis? Non-toxic, non-malignant.
So, non-malignant multinodular goiter involving the left lobe, sir. Predominantly.
Both the lobes, say both the lobes.
Both of them.
Yeah. How to proceed? How
So,
do you proceed?
first we have to do the routine. First, we have to do the TFT, sir, to confirm the thyroid hormone status, sir, for
Yeah,
this
very
patient.
good.
The
Thyroid profile.
TFT, so to check the thyroid profile test should be done, sir.
Good,
So
good.
after which we can do an ultrasound, sir, USG thyroid to check for the status of the nodule, sir, based on
Yeah.
hypoechoic or hyperechoic or all those based on
Is it
calcification,
solid,
vascularity,
liquid?
and also
Many
so
times
the
you can.
thyroid status can be assessed, sir.
Yeah. Non-palpable nodules can be seen. Non-palpable lymph nodes can
Yes,
be
sir.
seen. This is the advantage of getting
Seen. Yes, sir.
ultrasound, not only solid and cystic,
Yes, sir.
isn't it? Okay, then
Yes, yes, sir.
next investigation.
Then we have FNAC, sir. FNAC,
Yeah.
sir.
Yeah. Do you want to get blind FNAC or USG guided FNAC?
So in this nodule, since it's palpable left side, we can do a blind FNAC, sir.
Yeah, but first that we have to rule out by doing ultrasound of the neck because many times a 10 cystic
Neck.
swelling can be felt as firm swelling, isn't it? That is fallacy.
Yes, sir.
10 cystic swelling can be felt as
Yes,
firm
sir.
swelling. So if you hit that cystic swelling, you
Yes,
may
sir.
not get any material. So that is the advantage of doing
Yes, sir.
USG. If whole of the gland is solid, then you can get blind FNAC. If it is having both the components, solid and
Yes,
cystic, it's better to get done USG guided FNAC so that you can hit only solid lesions.
yes, sir.
Okay. Okay. Next.
Yes,
So
sir.
your FNAC report comes as nodular goiter or colloid nodules. How do you
Yes, sir.
proceed? Thyroid
Sir,
profile.
so based on the hormone,
Thyroid profile.
yes, based on thyroid profile,
T3, T,
for this patient with a new thyroid state, sir.
yeah. Clinically euthyroid, but biochemically there may be abnormality, isn't it? There may be low
Yes, sir.
T3, low T4, high TSH, or because of drug induced, there can be normal T3, T4, but low TSH. Anything is
Yes,
possible
sir.
with the
Yes, sir.
medication. But suppose
Yes,
that
sir.
T3, T4, TSH
Yes,
are
sir.
normal. T3, T4, TSH are normal. How do you want to proceed?
Sir, so we can proceed based on patients. If cosmetically, if she wants, we can do a total thyroidectomy, sir. Since it's a
So
large
you want
goiter,
to
and we can. If the patient wants cosmetically, sir, but symptomatically, and since there's no other trick or any other malignant features or any compressive symptoms or any other positive findings, and since it's not a toxic state, we can also continue with medication, sir. But prolonged MNGs can also convert into follicular carcinoma, sir. So patient has to be in follow-up, sir.
Yeah. And there is no clear-cut absolute indication for surgery in this patient because there is no any pressure
Yes,
symptom, no evidence of toxicity, no
yes, sir.
evidence of malignancy, isn't it?
Yes,
You can keep a close watch
yes,
on
sir.
the patient. If patient wants surgery,
Yes, sir.
if patient is willing for
Yes,
surgery
sir.
because of indication like cosmesis or maybe your future worry of malignancy development, you can proceed with
Yes, sir.
surgery. As such, surgery is not the
Yes, sir.
only remedy for a goiter,
Treatment.
right?
Yes, sir.
Okay.
Yes,
So
sir.
if you want to plan for surgery, patient is opting surgery because he is worrying that
Yes, sir.
future she may develop malignancy. As you are telling, there is higher chance of development of follicular carcinoma. So she is worried of that. She
Yes, sir.
wants surgery. Which surgery you want to do?
So we can ideally do a total thyroidectomy, sir.
Total thyroidectomy. Okay. What are the types of
Yes, sir.
thyroidectomy you know?
Because, sir, hemithyroidectomy, subtotal thyroidectomy, and near total thyroidectomy, sir, and total thyroidectomy.
So four types of thyroidectomies are there, isn't it?
Yes,
There's something called
yes,
as
sir.
radical thyroidectomy. There's something called extended. You have to read them. What is the difference between
Yes, sir.
near total and total?
So near total, we remove one full lobe, the isthmus, and the remaining lobe, except 4 grams of tissue, sir. That is near total, sir.
So we're going to measure that 4 gram of tissue has been left behind.
No, sir. No, sir. We're not going to measure.
Hmm.
No.
Total means?
We remove the
Total
entire,
means?
both the lobes and the isthmus, sir.
Yeah, without leaving behind any part of
Total means
the.
we remove the tissue.
Yeah. Why do you prefer doing near total versus total?
So the total patient definitely post-operatively must continue on thyroxine, sir. So near total, because of remnant tissue, that might compensate for the thyroid hormone stay supplements, sir.
Yeah, in this case, since it is not a case of toxicity, toxic goiter, since it is not a case of malignancy, isn't it?
Yes, sir.
But in case of
Yes, sir.
malignancy and toxicity, there is a role for total thyroidectomy. Because
Yes.
recurrent thyrotoxicosis is difficult to manage, isn't it?
Yes,
And
sir.
same other thing
Yes, sir.
applies for what is good for malignancy also. Since it is not a case of
Yes.
malignancy or toxicity, you can proceed with near total thyroidectomy.
Yes, sir.
Is it right? Hello,
Yes, sir.
Dr. Lalit?
Yeah, yes, sir.
Can
Yes,
you
sir. Audible, sir. Yes, sir. Audible.
can you enumerate post-operative complications after thyroidectomy? Post-operative
So,
complications?
in immediate post-operatively is hemorrhage, sir. So there could be reactionary hemorrhage and primary hemorrhage, sir. And then patient can develop
What is the
respiratory
difference
distress.
between reactionary hemorrhage and primary hemorrhage?
So primary hemorrhage within 24 hours, sir. Reactionary hemorrhage within 6 hours, sir. 6 to 12 hours.
Primary hemorrhage 24 hours, reactionary hemorrhage 6 hours. Huh? Are you telling?
Yes, sir.
Are you interchanging them? See, primary hemorrhage is the one which occurs intraoperatively, isn't
Okay,
it? Or
sir.
within
Yes.
6 hours.
6
That
hours.
occurs
Okay.
first. Primary hemorrhage is the first. Then comes reactionary hemorrhage within first 12
Yes,
hours,
sir.
isn't it? Or you can say up to
Yes.
24 hours also. What is
Dr.
the cause of
Lalit,
reactionary
Yes.
hemorrhage?
Yes, sir.
I will give 3 scenarios.
Okay.
Post-operatively, you are kept drain, and
Yes, sir.
patient develop
Yes, sir.
shudder and tingling numbness. What is your diagnosis? What you will think about that?
Sorry,
First
sir. I
scenario,
couldn't hear
you
you,
are
sir.
kept drain after thyroidectomy,
Yes, sir.
drain is functioning and patient develop tingling
Yes,
and
sir.
shudder. What is your diagnosis? In second
So this
scenario,
could be because
there is no drain, patient develop breathlessness, stridor. What is your
yes,
diagnosis?
sir. Yes, sir. So in the
And
first scenario, it could be because
third scenario, after removal of the large goiter, patient develop breathlessness or stridor. What is your diagnosis?
so in the first scenario, it could be because tingling numbness because of parathyroid
Okay.
injury, sir, or parathyroid are removed along with the
So which
thyroid, sir.
investigation you will do?
We can
Immediate
do
post-op.
check for ionized calcium, sir.
So how will you manage?
We have to give injection calcium gluconate, sir. 10 ml, 10% of calcium gluconate, 10 ml in over 10 minutes, sir. Initially.
Okay. In second scenario,
Second
patient
scenario,
without
when
drain.
patient develop without any, it could be one on hematoma, sir, an acute
Okay.
hematoma that can be relieved by opening the stitches.
Okay.
And in the third case, after removing the large multinodular goiter, patient develops stridor. It could be because of if the recurrent laryngeal nerve of both sides are injured, that can cause
No.
acute.
What is tracheomalacia?
Tracheomalacia is when the rings around the tracheal are damaged. So patient gets a scubbed or dilated trachea, sir. It's because of the large goiter, sir, because of constant pressure over the trachea.
So answer here is the tracheomalacia. How will you manage if patient develop tracheomalacia?
Tracheostomy should be done, sir.
Okay. Continue.
Yes, sir. The 3 scenario.
Very
Dr.
good.
Lalit?
Dr. Lalit.
Yes, sir.
How will you manage a patient of medullary carcinoma thyroid surgically? What are the surgical management?
So in medullary carcinoma thyroid, it is always one stage above. So if the patient is within the intrathyroid lesion, so then total thyroidectomy with central lymph node dissection and MRND should be done, sir.
And would you like to go for some genetic screening also in these cases?
Sir, these patients are middle thyroid carcinoma should be for MEN2 syndromes, MEN2B syndromes, sir. So they should be checked for pheochromocytoma also, sir. So there should be a carcinoembryonic antigen assay should be done, sir.
And how will you monitor recurrence in these cases?
We can do calcitonin estimation, sir. Calcitonin
And-
conversion rate.
Yeah. There will be mutation in red oncogene, red proto-oncogene, isn't it, in medullary carcinoma?
Right.
That can be done in a basic
Yes.
investigation because that can run in families, medullary
Yes.
carcinoma. Associated with
Yes.
other endocrine neoplasm, as you are told, you can have to rule out pheochromocytoma. Right. Very good. Very good.
Yes, sir.
If it is familial, what is the commonly affected age group in medullary carcinoma? If it is familial,
Second and third decade, sir.
you will talk about early part of the early age group, like during childhood.
Yes, sir.
Children,
Yes.
children itself it can occur or second decade.
Okay.
Second decade. Whereas sporadic medullary carcinoma can occur anywhere afterwards in adult age group.
Okay.
Very good.
Yes, sir.
So where do you want to take the incision in a case of thyroid surgery, thyroidectomy? Classical incision?
So 2 centimeters. So 2 centimeters above the suprasternal notch, sir. Coccus incision is made extending between the sternocleidomastoid, sir.
2 centimeters above the suprasternal notch. Is it transverse? Is it curved?
The transverse, sir.
What should be the
Transverse. Curve.
Not a straight transverse. It is slightly curved toward the manubrium, isn't it? Or arc shape, you can say.
Yes, sir.
Arc shape.
Where to
Why
cut
not above
platysma?
that line? Why not above? Why not below? Why you want to take only 2 finger bits above?
Sorry, sir?
Why you want to take only 2 finger bits above the suprasternal notch? Why not above or why not below?
Sir,
You can take anywhere. Incision can be taken anywhere in the anterior aspect of neck, isn't it? If you take incision at a lower level, the pedicle ligation will be very easy. Inferior pedicle ligation. If you take incision at a higher level, the superior pedicle ligation will be very easy, isn't it? So why you want
Yes,
to
sir.
take only at that level? Some region.
Dr. Sumit. Dr. Sumit,
Sir, sorry, sir.
where to cut platysma and why? At the level of skin or?
Sir.
And why?
So after putting in, we create a flap has to be subplatysmal flap is made, sir. So flap is raised both superior and inferior.
Hey, where to cut the platysma? At the same level of skin or something different?
So below the level of skin, sir.
To give
Why?
a better scar mark post-operatively, they can be cut at a different level.
Okay.
Isn't it? So why is the
Actually,
incision at a
sorry,
higher level?
I just want to say something. The
Please.
skin incision is taken
Yes, sir.
2 fingers just above the notch, because if it's taken much higher up,
Yes, sir.
the incision will be visible. It's taken much lower. Because of gravity, after some time, the incision moves down
Good.
and will be visible at the necklace line. So that
Yeah.
is why it is taken at
Okay.
2 fingers
Yeah.
just above.
Yeah. One more reason is if you take at a too lower level, there is a higher chance of keloid formation, isn't it? Why it is not
Yes,
taken
but
and why it is not taken at a higher level is you know the normal anatomy of the thyroid gland. Thyroid gland they usually don't extend superiorly because of limitation. The pretracheal phase is attached to
Yes,
the
sir.
oblique line thyroid cartilage, isn't it? So no need to take an incision at a higher
Yes,
level.
sir.
And these decisions should be able
Yes,
to
sir.
give them. Okay.
Yes, sir.
Dr. Nishkant sir, any questions,
Sir.
sir? Want to
No,
ask any
sorry.
questions?
I already covered most of the.
It is 10 p.m. already. But Lalit had done very good presentation.
Very good presentation.
Yeah, sir. There are very
Very.
few negative
Thank you,
points
sir.
about his
Definitely.
presentation. Very good history presentation as well as examination
Yes, sir.
findings.
Yes, sir. Yes, sir. Yes.
He
Yes,
could
sir.
summarize well.
Thank you.
Congratulations, Dr. Lalit. Keep it up, and do your best
Thank you, sir.
for
Thank you,
in the
sir.
examination. Okay.
Thank you, sir.
So
Thank you so
question,
much.
sir. Rajesh, sir.
Okay.
Any question, sir? Raju, sir?
Sorry, it's not.
Okay, you go. You only can conclude, sir. Nishant, sir.
Yes, please, sir.
Dr. Lalit, it was a really excellent presentation.
Sir.
You answered most of all the
Sir, thank you,
questions.
sir.
Reading the standard textbook,
Thank
join the PT clinics regularly and get clarified your
Yes, sir.
doubt. As most
Yes,
of
sir.
the
Sure, sir.
national
Thank you so much.
examiners are present here in this session.
Yes, sir.
Thank you.
Yes, sir. Thank you, sir.
Congratulations.
Thank you so much. Thank you, sir.
Dr. Sai, sir,
So,
some closing comments, sir.
I'm sorry, sir. I was slightly distracted all through. So, please. Anyone else, please do the honors.
Manjuna, sir.
Okay, sir.
Okay, sir.
Okay,
Shall
sir.
we wind
Thank
up
you.
the discussion?
Yes, sir. Please.
Okay, sir.
Thank
Good
you.
night, sir.
Good
Good
night,
night, sir.
everyone.
Good night.
It was a
Good night,
session,
sir. Good night.
Thank you for the sir. Good night, sir.
Thank you, sir.